Hey guys,
Hiya.
I saw that Jeff texted and said he has to staff something right now.
Okay.
So let's see. I'm trying to make sure that I can actually record here. Oh, are you recording or somebody is?
No, no one is recording yet. Let's have a look.
It says at the bottom of mine that it's being recorded. So I wonder if Jeff has already started.
I see that now. I see that
Okay.
now. So I think he probably did.
Well, I guess I'll go ahead and start us off. Howard, do you want to show cases first? Or I see David's back this week.
Okay, I can show a couple. Sure.
Okay, let's see. Let me, I'll give you control then.
Okay, let me start with this one. David, can you hear me? This is for you.
Great. I'm here.
Great. Okay. This is a really nice case of diaphragm eventration. I hope you'll agree with me. So here is a radiograph that is a recent one. When we look at the pattern of elevation of right hemidiaphragm, it involves a good portion of the anterior diaphragm, but the posterior diaphragm is in the normal location compared to the other side. And going back to May of this year, this being October, we can see that it isn't new in relation to the anterior diaphragm from then. So when we go to the CT and we look at the diaphragm, we'll see that particularly in relation to the posterior diaphragm and the right crus, that there is no atrophy of the muscle. And if I scroll through the sagittal projection and go there, well, we can see that the anterior diaphragm has normal muscle thickness as well in this portion until the diaphragm is buckled upwards by the liver. So this portion, by inference, is thinned, but this portion isn't, nor is the posterior. So they were still concerned about hemidiaphragm paralysis. I'm going to show two sequences from the fluoro. And here, as we've talked about before, it's really important to fluoro in the lateral projection so one can see the entirety of the diaphragm. So I'll start this, and this will be, first of all, even with a normal breath, one can see the posterior diaphragm on the right side moving. There's a deep breath. Here comes a deep breath there, so it does go down. And the anterior portion over here kind of stays there. This is going to be the sniff, so I'm going to put my cursor here where the dome of that right elevated hemidiaphragm is as it plays, so that you can see whether there is paradoxical elevation of the anterior portion relative to my cursor, whereas the posterior portion goes down. So up in front and down below. So for the first part, I'm going to put my cursor there and boom.
Yep.
One more sniff coming up like that. So I think the finding is pretty typical of eventration. Yes, there's paradoxical elevation of the anterior portion, but there is appropriate motion of the posterior portion. So that kind of up and down that we've seen before. David, am I right?
Yeah, you're all over it. That's excellent.
Yep, that's what you taught us, and that's what this case shows very nicely, right?
Mm-hmm.
All right, great. Here is a case that if I remember, Trevor showed an example once before, maybe quite recently actually, so he'll remind me. So this is a time X when the chest has not been operated upon, and on the 20th, next day, the patient is just post-operative. We see the usual things, including the sternal wires. Now I'm going to show you an exam from the 27th, after the patient has obviously left the ICU. And I'm going to, sorry about that. Let me try again. Something happened there with my cursor. Okay, let me make this big. And let me bring this up. So at this time, if we look at the sternal wires, the top three, first of all, they're all actually intact. The top three are straight, but these three have moved a little bit rightward. So intact, but the alignment of them has changed. And this is soon after surgery, just about 7 days. And you'll see what happens next. I'll show you a radiograph from the 5th of August. And now you can see all these sternal wires have moved rightward, and a substantial gap has appeared to the side of them. And indeed, you'll see that there is substantial abnormality of the sternum, with the wires moving rightward with the right half of the sternum, but otherwise the sternal incision is quite dehisced. So Travis, am I right? Did you show a case very similar to this one?
Yeah, I've shown not that much air. That's impressive, but yeah, I've shown dehiscence cases. Yeah, that's a pretty, obviously that first radiograph from the 27th is very subtle.
Yeah.
But that's what you look for. And yeah, and I've never seen a wire that fractures in the acute setting. You know, usually the wires don't fracture until years after the sternum is healed. So like you said, it's the separation and the malalignment that you're looking for.
Yep. And they just basically drag out of the left side in this case. Yep, pretty dramatic. Early separation. All right, let me show you this one. This is a really interesting case, and I will tell you that, and I'll show you the history in a moment, but the patient developed skin disease, which was biopsied, and then on further evaluation was found to have lung disease. So on the radiograph, this is from 2017, we just have foci of subsegmental atelectasis in the lower lungs. And then I'm going to show you the PET-CT. So at this time, we have nodules, multi-lobar, bilateral, different sizes, relatively large in the left lower lung. I will show you that these are pretty FDG avid nodules. And the diagnosis here was made by virtue of the skin lesion. So anytime you see lung disease and skin disease, and it isn't an infection, and you think it might be some kind of lymphoproliferative disorder, particularly if there's also skin, nervous system, and I think bone, but particularly nervous system and lungs, think of this particular lymphoma. So this is lymphomatoid granulomatosis. So you can see he had a scalp lesion. It is EBV positive, which is pretty common with lymphomatoid granulomatosis. But the combination of nodules, cavitary nodules, and skin disease particularly should make one think of that. Oh, the other thing that was really interesting here is that, as you can see here, he has a long history of Crohn's disease. It's been treated with azathioprine. There is a note that somewhere it was discontinued, but the reason I bring that up is that in the context of lymphomatoid granulomatosis, it is sometimes, as you can see here, or sometimes develops as a form of so-called iatrogenic immunodeficiency associated lymphoproliferative disorder, as you can see there. So one can reasonably speculate that this actually may be the case in this person, that this is a consequence of the immunosuppressive therapy that he was being treated with, as you can see there. So really classic combination of lung nodules and skin disease from lymphomatoid granulomatosis. All right, this one I show because it's a really nice pattern, but I also have a biopsy that goes along with that. So of course, this patient has an interstitial fibrosing lung disorder. Looking at the radiograph, one can see that the profusion of the opacities is upper lobe predominant. Some of the subpleural opacities are actually quite large rather than being the usual thin reticular opacities. And the hilo are pulled up, particularly on the left side, because of some generalized scarring and volume loss in the upper lung zones. And I will show you, just for comparison, that not too much happens in this period of time. So now we have, let's see if I can do this, a comparison between February 17 and August 18, and pretty much the same findings are there. So it's not particularly aggressive in terms of its progression. And then when we look at the CT pattern, so let me bring up some thin cuts here, right here, and I'll blow this up. We can see that the opacities in the apical lungs and the subpleural portions of the upper lung zones are particularly large, more than just reticular opacities, where most of the volume loss is. Then, of course, we do have areas of fibrosis as we go down elsewhere, manifested with areas of traction bronchiectasis, subpleural traction bronchiolectasis, and more disease lower down, but the size of these opacities down here is certainly less than above. And then the other finding, and I hope it shows up, but to my eye, there are areas of lung, like right here, in which there's relatively low attenuation. And I saw a few more like that. So lobules of relative hypoattenuation. I don't think I have in this patient the expiration images, but I would certainly wonder about whether we have foci of lobular air trapping. So I think there's a nice correspondence between the upper lung zone pattern of fibrosis, which goes along with pleuroparenchymal fibroelastosis, and the other disease, which you see from the biopsy, has findings of both. So we also have findings consistent with chronic hypersensitivity pneumonitis. So I think there's really nice correlation here between the imaging findings and the path findings. And certainly we associate pleuroparenchymal fibroelastosis with post-transplantation, but nowadays if you go to Google and you look for case reports, you can see descriptions of that pathology in a diverse range of conditions, from familial pulmonary fibrosis to even hypersensitivity pneumonitis. So I thought I'd share this case of a really nice path correlation.
You know, Howard, that's interesting because it's been, also been described with the UIP pattern, seeing the PPFE admixed with it as well.
Yeah.
It's probably just, it may be part of the same type of injury, and it's just, we see that pleural involvement more for whatever reason. I mean, the other thing we think about would be a connective tissue disease with the pleural involvement, but I agree, it looks like HP, and you've got path that supports it.
Yeah, exactly. Okay, let me stop there, and I can show more if you need me to, but I can save my other ones for another time, of course.
Okay. Travis or David?
I have a couple I could show. So this is a fellow from a desert region of California near Palm Springs who was on a cruise in Alaska and got sick and was transported to the University of Washington. And he has this radiograph near the beginning of his course here with lots of consolidation, worse on the left and particularly in the left base, accompanying pleural effusion as well. And at this time he had his CT scan, and this is outside CT, which shows all these peribronchial nodules and consolidation, a little bit almost tree and buddish over here, really dense consolidation in the left base, and accompanying pleural effusion. Not much in the way of lymphadenopathy. So things moved along here, and this is what his radiograph looked like about a week later. Now the consolidation is a lot more extensive. He's had respiratory insufficiencies, had to be trached, so he has a tracheostomy tube in place, still has left pleural effusion as well. And here is the CT scan now at this later time, and you can see that there are all these cavities here, interpreted as micro abscesses. I think that's a good possibility for this pattern here. And this fellow was at this point in a coma. He had brain imaging and he had CSF studies, and nothing was detected. So I think he's recovering some mentation. He's able to respond now to pain and stuff like that, but hasn't opened his eyes for a while. And on bronchoscopy and on sputum, they recovered coccidioides in this. So this fellow probably acquired his cocci in a Southern California desert location and didn't get sick until he was on vacation in Alaska on a cruise ship. And this is overwhelming cocci. So they identified by the DNA that it was either Posadaceae or Immitis. I think those are closely related species. And this is extensive cocci now with a micro abscess pattern and a bad pneumonia. So cocci, it's all over the place. So when somebody comes down from Alaska, you have to wonder where else have they been, because people move around so much. Okay, now here's a patient with a cough, and the cough is all day, and it's keeping family members up at night. And this patient had a history of a neck tumor, a superficial neck tumor that was removed, was resected, and was not subject to histologic analysis, but was presumed to be a sarcoma. And that was about a year ago, because evidently there's a susceptibility to a particular spindle cell sarcoma. And there is consolidation in this right lung base here. You can see this triangular consolidation in this base down here. And it was presumed, and there are some lung nodules elsewhere. So it's presumed that this is malignancy. It might be a primary lung cancer. It might be metastasis. Maybe there's endobronchial involvement. This is one of our office, our statistician dog, which is 17 years old. And, you know, I think there's a nice lower lobe collapse pattern here. Now, dogs have a cardiac lobe, which is, in humans, corresponds to a medial basal segment. So the medial basal segment is a separate lobe. So the inferior accessory fissure in humans is complete in dogs, and it gives rise to this lobe down here. So this could be a cardiac lobe. It's a very nice triangular shape down here. It's consolidated. Other considerations are aspirated foreign body or infection with mucus plugging leading to this collapse down here, but tumor is the top of the list, especially with nodule looking things like this that also look like tumor. So maybe it's a primary lung cancer, maybe it's metastasis, maybe there's some other cause of this lobar collapse with infection. So at 17, this dog is 106 or 107 human years equivalent, and you know, the dog has other problems too related to old age, so there's not going to be aggressive therapy, but they was elected to have a course of antibiotic to see if there was potentially infection that could be cleared up and maybe everything would go away. But the owner is expecting that this will turn out to be a malignancy and will probably be fatal. Okay, so you don't get to see very many canine x-rays around here, so I'm always grateful. This is
David, I was hoping you were going to show a diaphragm case with a sniff test in a dog. That would have been the ultimate.
Dogs are good at sniffing. I mean, they're pros when it comes to sniffing. There's nothing like it.
David, what breed of dog was it?
Well, I will collect that information.
Okay.
And relay it.
One of my dogs had tracheomalacia when he was older, and I know that small dogs are prone to that, so it's another chronic cough issue.
Right. Okay, this is a human with a cough, and this person, I think, who is in her or his 40s at this point, was a was an athlete, I think a track star in college and stuff like that, exercised fully, and a diagnosis of cystic fibrosis was only made late in life. I think, probably around the age of 30 or something. I'll check the records and clarify that. And this person has fairly mild bronchial disease here, does not have a typical mutation. So atypical mutations, and probably that helped account for the late onset or the late recognition of cystic fibrosis. But this person developed a serious complication of cystic fibrosis, which is development of colonization and infection with Mycobacterium abscessus, which is a very aggressive and very hard to treat organism. And that is what has led to these big cavities in the upper lungs. So still there's fairly modest bronchial disease in this person, but a lot of cavitary disease from the abscessus here, which is a horrible infection. So this is bad for a number of reasons. Not only is it very hard to treat in the patient and a cause of lots of morbidity, but it's also transmissible to other patients. And so it's possible to have these patients in clinic infect other patients just in the waiting area. And another bad organism was brought out in a conference this week that affects these people, that's really a devastating thing in the setting of cystic fibrosis, is Burkle Dariya infection 2. So used to be called, I think it used to be called Cepacia, but now it's Burkle Dariya. And this person does not have that, but that's another disastrous infection that affects the cystic fibrosis population. So this is M. abscessus causing this cavitary lung disease.
David, David, I know here at our institution, if they have M. abscessus, they won't list them for transplant.
Right.
That's true.
And so that's the situation here too. I don't think this person's a transplant candidate because of this. So look at the bronchial disease here. It's fairly modest. This person just doesn't have the typical widespread bronchial disease of the typical cystic fibrosis mutation. M. abscessus with cavitation. And I think those are the 3 cases I have so far. So I'm sorry, I'm trying to organize this stuff. I have some other cases. I'll show them next week.
Those were excellent. Thank you.
Thank you.
All right. Travis, you ready?
Oh.
Or I can go like Travis is. All right. What we got
Travis got a better offer.
here? All right. Let's see. So along our history of some of our cases we've shown of sort of recreational type drug things, this is a young man who came in with shortness of breath and hemoptysis. And you look at the radiograph and you can see there's clearly nodules in this left lung and maybe a few on the right, but maybe a good look for pulmonary hemorrhage with that that history. But of course, infection would be pretty high on the list as well. But I did get the history that he occasionally smoked marijuana, but his recently had been vaping, and I'm not sure what particular compound he was vaping. They wanted to look for pulmonary embolism, which he doesn't have, but he's got just these beautiful acinar type nodules. So central lobular, but sort of blossom almost filling the entire lobule, but you can really see how the fissure is spared and subpleural lung is spared. So I thought this was a pretty good look for acute diffuse alveolar hemorrhage in the setting. And so he was admitted, required a little oxygen, but not much else. I think they gave him a dose of antibiotics just in case. But they did do but it wasn't until about the next day or maybe about 36 hours later, he finally got a bronchoscopy. And the BAL did not show some blood, but it didn't show increasing amounts of a little bit of interstitial emphysema in here too, kind of neat. Didn't see the increasing amount of blood returning. So it wasn't a great look for DAH, but I wonder if the DAH was long gone and there was just some remnants of blood in the airways and they didn't really see active bleeding. But this is, there's no other, never had an infection, never had any other exposures. So this is presumed from vaping some compound that somehow injured the lung or triggered an immunologic response that led to this this hemorrhage.
So Jeff, you said they did get some blood back on
A little
lavage.
bit. They didn't get the typical increasing bloody return, but they did get a little bit of, they saw a little bit of old blood in there. So I wonder if this is what, he just bled and stopped because he's, by the time they got to bronching him.
And he had presented with hemoptysis?
Yes.
I missed that part.
Yeah,
I had to restart.
Short of breath, hemoptysis, had recently been vaping.
So, you know, the pulmonary hemorrhage is classically crack cocaine. You know, that's a big cause of hemorrhage.
Right.
But he didn't seem to be, it wasn't his.
Yeah, no, he was forthcoming with what he took. So, I mean, it was marijuana on occasion, and then really it was sort of a big time vapor. I don't know. This is the first vaping one I've seen, but I can't figure out exactly what he had. Now, this is a fun case. So this is a 42-year-old woman who presented short of breath, chest pain, has a very large pneumothorax and collapsed lung. Not particularly exciting, but you know, we get CTs of these patients looking for bullae, blebs, all that fun stuff. And we see she's got some gas tracking up. But what's really cool is, so she's got a little cystic space in the apex, is if you look very carefully through the lungs, let's see if I can find some. She has some little holes in the lungs. There's some in the other lung as well. There are not a lot of them, but she does have some of these holes that look like cysts. I thought there was one on the left somewhere. I can't find it right now. Yeah, so, but what gets interesting is when you go further south and you get into her, so she has a drain, and you look at her kidneys, she's got all these fatty nodules in her kidneys and liver. She's had some surgery back there. And then for Travis, we've got this little fatty deposit in the heart. So this turns out this woman has tuberous sclerosis complex. So I think she has very little lung involvement as far as cystic disease, but clearly one of these was enough to rupture and give her a pneumothorax. So sort of a TSC-associated LAM with just not really disease, but some of these cystic spaces related to it, like we see here.
So Jeff, are the heart tumors also angiomyolipomas?
I don't know the answer to that. Maybe Travis knows, Howard. I don't know.
It's hard to get a good answer on that histologically. We always just call them intramyocardial fatty foci. I've never had one that was actually biopsied, you know, personally, but I don't know. I'll have to look and see. Unless Howard knows.
Yeah.
No, I don't. I always just describe them as such as well.
Yeah.
When on occasion we see it.
Okay. So this is follow-up of a case I showed last week. So let's see. I'll make sure I show the right image. I'll show the old CT first. So this was the IV drug user who came in sick, who has septic emboli everywhere, and this monster vegetation on the pulmonic valve. So it turns out the next day, I was asked about if I'd seen the follow-up, and of course, no, I hadn't. And so here's the CT from the next, the day after I presented the case, so a week later. So that vegetation is no longer in the pulmonic valve, it's now in the right pulmonary artery. And you can see it's sort of infarcted a good chunk of the right lung. So this patient was not doing very well. And you can see there's acute right heart dysfunction. So he went to the OR and they cracked his chest, and they also had the thoracic surgeon come in. So they had to replace the entire pulmonic valve. Two of the leaflets were in bad shape, and one of them was gone, wasn't there anymore. And they removed this, and there was just frank pus in the pulmonary artery. So they did an embolectomy, but he really just trashed this right lung here. So just multiple areas of what looks like hemorrhagic infarction.
Gosh.
Yeah.
That is bad.
Yeah, that is bad. And he was, if you remember, he's the one that had the needle fragment still. I don't know if it was still there or not. There's the needle fragment from his injection. So that's bad. And then here's another bad case that's sort of related. These are kind of all acute things. So this is a patient who presented with some chest pain, and you can see she has this cavitary mass in the right lower lung, pleural effusion. You might wonder about an abscess. It kind of looks very abscess-like. On the lateral, whoops, where's the lateral projection? I don't have thought I did. But here's her old radiograph from a few weeks before, and she had this peripheral nodule and pleural effusion. Kind of looks like this is evolution.
So now it's backdoor. I'm having to use a
access.
for
But
the audio. But
and she had had an MRA at that time, at the initial radiograph, that showed this actually is a pulmonary. It's not the best study, but there is. Let's see if I can find it. Yeah, it's not the best sequence. Let's try a different one. Oh, sure. Here we go. We can follow the pulmonary artery down. We see there's thrombus in the lower lobe, in the interlobar, and going out there. So this is an area of probably hemorrhage or infarct or whatever we want to call it down there. So this is actually not an abscess, but evolution of that infarct. They did a CT because the concern was what was going on, and you can see the area right there has now cavitated and ruptured into the pleural space, and there's a little nice bronchopleural fistula going right into the space. So it's really a broncho-infarcto-pleural fistula. But I've never seen an infarct disrupt the pleura. So I wonder if this got super infected. It turns out this patient has alcohol abuse, drinks a lot, probably an aspirator, hard to be 100% sure. There's another little infarct out here. But I wonder if this thing got super infected and then it caused empyema. But have any of you ever seen this happen where what at least looks like a bland infarct ruptures in the pleural space?
No, I've seen cavitation infarcts, but not that, I don't think.
Right. The cavitation itself is so rare, and this thing kind of got big, but somehow it had to erode through the pleura and spill in there. But yeah, so they had to manage this as a sort of an empyema there with a fistula.
Gosh.
Let's see, we got a little time left. This is just a quick cute case, something I noticed. I saw this last week. I can't remember, this was some surveillance case or something, but I saw this diverticulum coming off the descending aorta. I thought this was going to be maybe an aberrant vessel, maybe an aberrant right vert, but if you look at it, the only thing that comes off of this is this little intercostal artery here. So I can't explain why it's there embryologically, because we often see the diverticulum because of the ligamentum arteriosum, but that's over here. We can see the ligament right there. So some weird cause of this, but I've never seen one without an aberrant vert or aberrant subclavian artery.
Yeah, I thought you were going to go with the right vertebral artery. Does the patient have a right vertebral artery?
Good question.
Comes off normally?
Yep, there it is right there.
Huh.
Just one of those things, add it to our list of aortic anomalies. All right, and then quickly, 2 cases of the same diagnosis in the same week that had normalish CTs beforehand. So this is a patient with, which one was this? This is a patient who has a history of colorectal carcinoma, came in short of breath, and just has exquisite septal thickening. This is another case this is lymphangitic carcinomatosis, but it's interesting. I'm showing it because it has those lymphatic lakes or pearls that we've talked about in this conference several times. And we always talk about in the setting of lung edema, cardiogenic edema, but in this case, this is all edema because of lymphatic obstruction. But I thought this was very striking. These are some of the best lymphatic pearls or lakes I've seen. It has the thickening along the bronchovascular bundles and the shagginess to it. What's interesting is I did find the PET CT that was done a week before, and I don't know if it was done here or not, but why it's not giving the right lookup. There we go. But you can see there's diffuse uptake all throughout the lungs. I mean, this patient has lymph node metastases. I mean, there's metastases everywhere in this patient, but the lungs had too much activity. You can see on the fuse, and I think this is picking up all the microscopic foci of tumor that we can't see directly in the lungs. Here's the MIP. You can see it's pretty bad. So, and then this is a companion case, and this is one we see less often. This was a patient with a bladder transitional cell cancer who had no chest mets and then shows up like this, very decompensated. And this is the more typical appearance when you see the septal lines, but the really shaggy bronchovascular bundles, the dilated veins. Pleural fusion is present not infrequently. This was not left heart failure. This patient died shortly after admission, I think a couple days later, because they tried to make this heart failure, diuresed the patient, nothing. Echo didn't show much in the way of left heart dysfunction, did show some right heart dysfunction, which would fit with this increased pulmonary arterial pressures. They were asking, could this be anything else? And not really. This is a very nice look for a lymphangitic tumor. But I haven't seen it much with a transitional cell.
Wow.
Wow.
Yeah, pretty bad.
I think that's everything I have this week. Yep. So some weird stuff, a lot of bad vascular things. I actually have another vascular case, but I don't have it ready yet. We just saw it today, but I'll show that next week. All right, Travis, are you ready?
Yeah, my audio wasn't working, so I had to restart the program.
Can hear you fine now.
Okay. So this is one that just came in today, and my colleague, Dave Nager, who's at the VA, showed it to me and was asking what I thought. And I want to show it to you guys. This is a 33-year-old patient, and you can see these airways in the upper lobes already. You can see how there's some bronchiectasis, and then you get like almost like this little rosette pattern around it, where it just looks like there's increased number of vessels surrounding these little airways. And it's really interesting because the only history we had was hemoptysis until we went digging. And this one right here, there's a little bit of fuzzy ground glass around it. So I wonder if that's some of the hemoptysis, but just a very peculiar look to these airways. It looks like there's, like I said, it's a non-contrast study, but it kind of looks like neovascularity surrounding those airways. And it's the same thing in the lower lobes. And we were trying to figure out what this was, and was wondering if he had a history of asthma. The distribution's not terrible for allergic bronchopulmonary aspergillosis, even though there's no mucus plugging in any of these, or something else in young patients. And it turns out that the only thing we could find was the patient does have a history of asthma and had a bronchial thermoplasty in 2010 or 2012, so a few years ago. And I've only seen, I've heard of that being done for patients with asthma, and the idea is you use like some sort of thermal injury to the airways from a bronchoscope to basically release the smooth muscle so you get less smooth muscle contraction. But I'm just wondering if you guys have any other ideas, like could this be ABPA or could it be EGPA associated with the patient's asthma and not a result of the bronchial thermoplasty? Because it's just a really odd look.
Well, yeah, I was wondering about GPA until you mentioned the asthma component, but I don't think I've seen EGPA cause large airway disease like this.
We've seen a couple of cases of like bronchiectasis, but it was more focal with EGPA, and I was never sure if it was actually the EGPA or some concomitant pneumonia, that just injured a specific portion of lung. I found this in AJR, which just talks about bronchial thermoplasty, and they only looked really at air trapping values and wall thickness, and then the only image they have in this study is like assessing the thickness of the air or the diameter of the airways and such. But I don't know. I was just curious if anybody has seen like post bronchoplasty or thermoplasty stuff to know if that's what this is or if it's totally unrelated.
Yeah.
And she's not a smoker?
Not that we don't know. It's very limited history.
Okay.
So it's just a weird look with these little shaggy airways.
Could I ask a question about EGPA?
Yeah.
There's a case that had a ton of lymphadenopathy and the diagnosis of EGPA, and that, with treatment, the lymphadenopathy went away. It really looked like sarcoid. Have you guys ever seen mediastinal and hyaline with EGPA?
Nope.
Not that I recall.
No.
Nope.
Could it have been sarcoid too?
Well, yeah, maybe there's more than one disease. I'll need to dig into that.
Yeah. But no, I have not with EGPA. Okay, well, let's see. I'm gonna go to this one. This one I told Jeff, I think I told Jeff and Howard about this a while ago. So this is a patient that came into the ED at the General a couple months ago, and she had a acute onset of abdominal pain, or what was termed as relatively acute onset of abdominal pain, and ended up getting a CT of her chest, abdomen, and pelvis. And unfortunately, there's no non-contrast study here. And my resident correctly thought that this was all just flow artifact and smoke in the aorta, which certainly, you can see the arch, very wispy, ill-defined, extends into the descending thoracic aorta. And then the ascending aorta looks a little bit big. I think in general, it's a small patient because this is still only, it's 3.9 centimeters. Ugh, come on. But what got everybody nervous was the fact that she had this high attenuation hemopericardium. And there was no other explanation for it. And she came in hypotensive. And I think you can see, what would be the CT sign of reduced output or early tamponade here with not only do you have a contrast refluxing into the IVC, but you essentially have a contrast fluid level where it's really just layering in the IVC and in the liver. So then the resident was overruled, and this was called a type A dissection because that, as the explanation for the hemopericardium. So the patient was transferred here and went to the OR to repair the type A dissection. Now, of course, they first went in and evacuated the hemopericardium. And the other thing I always look for is myocardial rupture as a cause of hemopericardium. And there was no source or no sense that the patient had a ventricular aneurysm or pseudoaneurysm that ruptured. So they went in and evacuated the blood, and the blood they described it as a lot of old clotted blood. So it doesn't even sound like it was that acute. But then what they did find, though, was in this area of the undersurface of the arch, there was what looked like a little penetrating ulcer that probably had been the source of bleeding. But of course, to their surprise, but not to our surprise, there was no dissection flap in here. So the patient needed to go to the OR anyway to get the hemopericardium evacuated. But it seems like it was just, there was some maybe old intramural hematoma that I don't know if it communicated along the ligamentum arteriosum or where it communicated. But furthermore, at the time too, they did delayed imaging, and you can see the abdomen and pelvis, and there's a neck as well, or maybe it was the whole chest they did. Yeah, but you can see there's no dissection flap. This was a delay that was done. But this is, again, the surgeon was not, aware of the flow artifact there and thought this was going to be a type A dissection. So they, other than the undersurface of the arch and a little penetrating ulcer, and I think you can maybe see a little bit of wall thickening of the descending aorta. Like I said, we don't have a non-contrast to really tease this out. But it's another fake out of sorts here with the smoke in the aorta.
But the whole smoke phenomenon was really the distal arch and descending aorta, not ascending, right?
Well, right here, yeah, that's just, yeah. And I mean, I guess if you can, you can always make it look worse than it is. But yeah, there was no dissection.
Right.
So Travis, you think it was a penetrating ulcer and not a ductus aneurysm or something like that popped?
That's what they said in their report. Yeah, and they, it was weird too because they never really said that frankly that there was no dissection. I talked to the surgery fellow though who said there wasn't one, but they said there was ulceration in the portion of the arch between the common origin of the brachiocephalic artery and the left carotid. So
well, that's not quite in the same location that we see that anyway, I don't think.
Well, they were saying there was something in here, and I don't know if the little ulcer then tracked down along the ligamentum. I don't know. I couldn't find a way to explain why there was hemopericardium, and nor could they. Right. Yeah. And their note was a little cryptic because their preoperative diagnosis was type A dissection, and that was only, when I talked to the surgery fellow offline that, they kind of said, yeah, there was no dissection. Okay. But I mean, the patient needed to go to surgery anyway to get this evacuated and explored.
Do you think there's left ventricular hypertrophy here, by the way, or is that?
Yeah, I think there probably is. It looks like we're during systole though, because the mitral valve is closed. But certainly, I bet she has longstanding hypertension. So yeah, I think that that's probably true. Now this is one, we've seen this a few times now, and I know everybody else has probably seen it too if you're doing any interstitial lung disease. So this is a patient, 74-year-old man, and not really a diagnostic dilemma. Yes, he has a little bit of emphysema, but if we characterize his interstitial lung disease that he has, it's a basilar and peripheral predominant process with traction, reticulation. And then when you look, you do find that there is some honeycombing, particularly here in the right middle lobe, and then a little bit in the posterior aspects of the lower lobes as well. So it's a definite UIP or consistent with UIP pattern. And of course, as we know, these patients are subject to increased risk of lung cancer. This was actually some sort of a neuroendocrine carcinoma when it was biopsied, and you can see the patient had bulky lymphadenopathy. So this was April of this year, and with his metastatic disease, he's not, and you can see there's probably a little dendriform ossification as well. Not a surgical candidate, but you can see a few months later that he's undergone chemo and radiation, and you can see just a really great response. And this is a couple months after the chemo radiation, and that's the beginning of August, and then he comes back in 4 weeks later and gets a PE protocol because he's acutely short of breath. And now you can see that he's got diffuse ground glass opacities superimposed on his underlying interstitial lung disease. And so we see these all the time because we have such a large ILD and pre-transplant population. And of course, the differential in these cases is always really some sort of pneumonia or infection versus acute exacerbation. And he underwent standard workup, he wasn't infected, he didn't have volume overload. And this is not the first case. We've seen a few cases now of radiation, presumably as the trigger of acute exacerbation. And of course, acute exacerbations have reported close to 50% near-term mortality, despite trying to hit them with steroids and everything else. And you can see a couple weeks later, he was getting progressively worse with ground glass opacities and ended up passing away a couple days after this. But we don't know I don't think anybody knows all the triggers of acute exacerbation, but this was all thought to be due to radiation. I think the time course is reasonable because it was within a couple of months when you would expect the radiation pneumonitis or lung injury to develop.
But this is so widespread, it's not the typical radiation pneumonitis in the field of radiation. So this is some systemic.
Sure.
Yeah.
Yeah, I think it's right. It's the radiation that's the trigger of the acute exacerbation.
Right.
Yeah.
Amazing. And so there was no diagnosis of alveolar damage or organizing pneumonia or something like that. There was no histology.
No, there was no histology. I mean, we've had a few that go to transplant, and that's what you get with this when you explant the lungs. But he wasn't a transplant candidate. Would be the acute lung injury or organizing diffuse alveolar damage, depending on the time frame. So yeah, I mean, but this is just the typical, presents with acute onset of worsening dyspnea with a known underlying interstitial lung disease and has this ground glass, and never really sure if it's going to be acute exacerbation or pneumonia until they've kind of worked him up. But in him, I think we have a pretty good trigger with the radiation. And then this one's an interesting case. So this guy's 65, and he comes in his history, the chief complaint that led to this radiograph was that he had a unilateral droopy eyelid, as his chief complaint was, or ptosis of the eyelid. And then on further exam, it sounds like he also had the meiosis with the constricted pupil. And so, given that history, of course, you're worried about some sort of superior sulcus tumor, namely affecting the sympathetic trunk. And that's exactly what this turned out to be. And you can see sometimes in this area, we think about just tortuous vessels, but usually, as Howard would describe, they have that lack of a cervicothoracic sign, or where you just lose the interface at the anterior mediastinum with a tortuous vessel. But this certainly looks more like a discrete mass, and you'll see that this is posteriorly located and presumably involving his sympathetic trunk here. So the sympathetic trunk gets knocked out, so you have ipsilateral meiosis, ptosis of the eyelid, and then anhidrosis would be the other part of the classic triad. And of course, there are other sympathetic symptoms you can have that I don't really remember at this point, but this was a true Horner syndrome from a lung cancer. So metastatic adenocarcinoma, I guess they did looks like he had some lymph nodes that were involved as well, and he had a contralateral paratracheal node here, so N3 disease.
And the rib was intact, right? Just
what's that?
The rib was intact.
The rib?
Oh, it doesn't really involve the ribs. It's more just adjacent to the vertebra.
Yeah.
Not really doing
Yeah, it might actually invade the vertebral body right there.
Oh.
It kind of looks like it encroaches on it.
Yeah.
So it's still a T4 just with the mediastinal invasion anyway, because you can clearly see it looks like it's extending behind the trachea.
Cigarette smoker or not?
I don't know. I'm guessing probably.
Did he have on the CT?
Let's see. Yep.
Yeah.
A little bit of airspace enlargement, fibrosis there, and paraseptal emphysema. Yeah. So presumably a smoker in that case. It was an adenocarcinoma though, not a squame. And then this one, show a couple more. I don't know, just if anybody else has cases to show, just let me know. We've got a couple minutes left, but this is another very young patient. I think this is we think about sarcoid in patients of this age all the time, and certainly you can see that he has a very lumpy, bumpy left hilum, maybe some AP window lymphadenopathy here with that little convexity, and then right paratracheal lymphadenopathy. Now, Howard, let's see,
just if you go back 1 second to that frontal,
yeah.
You don't mind? Because I'm looking at proximal left main bronchus.
Yep, good, right there.
Yeah.
Yeah, I was going to say too, we don't really see the azygoesophageal, the interface here very well, and that's why I was going to look at the lateral, especially after the case you showed last week. I don't know, maybe you do have some subcarinal lymphadenopathy as well as thickening of the intermediate stem line. You don't really see it right there, but
there's an extra bulge there, so just anterior to the airway, right? So
yeah,
there's something that up along.
So the reason, so we can confirm all of these findings, and of course, I think as Howard pointed out, that mass effect certainly would be unusual for sarcoid. But there's two other things that, I think at least that go along with the literature. A, this is pretty low attenuation lymphadenopathy, which always makes me nervous about sarcoid. And B, you don't really have the true symmetric bilateral hilar involvement. In fact, there's not really any right hilar lymphadenopathy, at least by size criteria.
Yeah.
And because he had been transferred in, billed as probable sarcoid, and we kind of backed off of that because those findings made me very nervous. And this ended up being a metastatic neuroendocrine carcinoma, even in a young patient like this. But they did an FNA, and it was an atypical carcinoid. So, and I guess there was some issue about TB as well, which certainly would fit more than sarcoid just because of the low attenuation lymphadenopathy. But these are the ones where I think, especially when it's not symmetric or if you have low attenuation, necrotic looking lymphadenopathy, not to mention the mass effect. I hadn't even really thought about that, Howard, as a something to sway you away from sarcoid.
And another feature too is that sarcoid nodes are very well defined. They have very clean fat, mediastinal fat around them, and these are smudgy. So this doesn't look like sarcoid lymphadenopathy at all.
Okay, that's a good point because they're more smudgy and more of just a big conglomerate.
Right.
Okay.
Amorphous and smudgy.
Because I found there's old literature more from I think radiography than CT, just talking about the distribution of sarcoid lymphadenopathy and how it's almost always symmetric bilateral hilar with subcarinal and paratracheal, the typical like 1, 2, 3 that you see.
So this was a lung primary, presumably.
Presumably, yeah, it was a carcinoid of lung primary, and I'm guessing it was somewhere in the left lung given the asymmetry of the hilar involvement. But as you can see here, not really, unless it was in a lingular bronchus to start, because that's the only airway that's being taken out there.
Or could it be metastatic from an abdominal source?
I think they looked and it wasn't.
Okay.
I think this was of lung primary, but regardless, with that pattern of lymphadenopathy, and all the other features we described, I think it's several reasons, to think it's not sarcoid.
Can you show the lung window one more time? Just
Sure.
I want to look at the left upper lobe, if you don't mind. It seemed to be blacker than the other lung, maybe. No.
Well, I think it's because the lingular bronchus here is taken out.
Okay, so they need some trapping. Okay, got it.
Yeah, so you see the left upper lobe,
Yes.
and then this is where the lingula should be, and it's knocked out. So whether there's a primary in the airway there,
Okay.
and then it leads to a little bit of it looks like probably the superior segment of the lingula just a little hyperinflated from being obstructed.
Yes.
So, okay, well, I think it's
time.
Stop now. It's 1 o'clock.
All right, great cases this week.
Hey, Jeff,